Thank you, Ripa. I think very inspiring story and a wonderful achievement in such a short period of time. In difficult circumstances, I think that requires our admiration. We're open for questions now. Oh, there's already one question coming.
Of course. Hello, Tanya Spanic, and thank you, Stefan, Jan, Jonathan, and Ripa for this great session. Really very inspiring, and I could go and comment and talk with all of you for 4 hours, but I will just stop with Ripa at the end because I'm biased to the breast cancer, and I have to say that I checked already while you were talking with our Evropadona representative in Armenia, and she said that you are such an inspiring person, and she confirmed everything that you've done. So really congratulations on your work, and I'm really looking forward. That's what we are doing also as a European coalitions, that we are not just talking about EU and EU member countries, and what we are trying to do is always address other parts of the world, not just Asia, Africa, Latin America, but also the part of Europe that is not that are not members of EU, European Union. So really thank you for this and for what you've all been doing. And just to confirm that we are aware of that, and we really don't want any cancer patient to be left behind in this world. And of course, also thank you to ESMO for giving us the voice and the opportunity to be there. Thank you.
Thank you, Tanya. Thank you, Tanya. It's not really a question, but it's more than welcome. A question I had was, I mean, you're all trying to change the system, right? And you mentioned it as the system. Jonathan did that. Are we making progress? I mean, Jan, you've been working on this for decades, you know. Are we making progress? Do you see that as a kind of patient centricity evolving? Is it being taken into account?
Well, of course, we're seeing progress. If I think of, I mean, I don't know how many years I've been coming to ESMO, probably first time 2005 or so, and we're a very marginalized community. Most of the umbrella organizations we know today either didn't exist or were just being founded and were in their baby stages. And of course, we're making progress because the community has been pushing hard for change on the policy level and so on. But I would say, I mean, ask Jan if he's ever satisfied. I was talking about satisfaction. I would say probably we're 10% where we want to be. That's what I have to say, but I think we've made great progress on that. But I mean, look at, if we just say, is cancer a solved problem? No. How many cancers do we have? 200. How many do I have? I have the privilege of survival in a disease in a cancer that we largely ticked in terms of therapies. Most patients in the world still can't access even the therapies we have. And that's why always I have to apologize that I'm an angry patient or an impatient patient. I think in most of the world, and we just heard that in Armenia, we're far away from where we need to be.
Okay, thank you. Jonathan, any reaction to that?
Well, that's kind of why I showed on the disclosure slide those organizations that do include me, and I know that all of you do that too. And so I think there's progress because we're talking about it, and I see presentations everywhere about it. What I don't think has happened yet, it's not systemic, it's not become the way of doing things yet. It's something special, and it is often down to individual, either patient advocates or physicians who believe in this, and there are wonderful physicians and their teams. My team is amazing, but I don't think it's become part of the way we do things. And it will, I'm sure. I always find, to kind of reflect on yours, I have there's a guilt feeling. I mean, I feel I'm alive. Why should I be complaining about things? And that worries me a lot. I kind of get over it because I think things can be better, but I think that a lot of patients feel that way. And that's something to try and conquer, I think, and get more of our voice out and say, no, it's okay, of course. Let's make it better for the next people. And that's what drives me. If we can make it better for the people that are treated after me, then that will be fantastic.
Okay, thank you. Ripa, what is your, I mean, you've made so much big strides in a limited time period. What persuaded the government and the other parties involved to work with you on that, to move forward?
I think because intuitively and also professionally, I always prefer to work openly and transparently, and strongly believe in what I am saying and doing. By my professional background, I am a program manager, so I apply systemic solutions, holistic approach and systemic solutions to everything what I deal with. So convincing the Ministry of Health doing the screening program in a true way that it should be done was like a strike between me and the state agency when I told that I will sabotage this program if you do not do that right, and go and talk to the health minister to find extra money, and the extra money was about $90,000. And when I told him that you're not going to need those $90,000 in an overnight, this is going to be spent during 2 years. And if you split those $90,000 by 24 months, it's less than $8,000 per month. So the money is there. You need just to search for it and find it. If you cannot convince the health minister, let me do that, and I will convince him. And another example with the cancer registry, I forgot to mention that we did not spend a dime on building the cancer registry. It was all labor force, working time of people on the Dutch side and on the Armenian side, meeting online and doing together. So the Dutch people babysitted Armenian specialists online to lead them the way how the cancer registry needs to be built. So we had our computers, we had the internet connection already established. It required just dedication, devotion of time, and leadership's acknowledgement and willingness, the power to make the decision, yes, go for it. But before that, you have to convince that this is the thing that you really need. And for so many years, I was trying to bring clinical trials to Armenia. There are none, and cancer patients in Armenia are deprived of that opportunity even to access experimental treatment. So as soon as any entity that is doing a clinical trial knows that there is no electronic cancer registry, they say, okay, there is no chance. What do I want to do to bring clinical trials to Armenia? Build the cancer registry, and maybe that would follow on to the clinical trial. Right. So my key message is, if you don't find the good evidence to support your work, your perseverance, then create your evidence and then use it.
Thank you. There was a person asking a question at the back. I know it took some time. Okay, okay. I have a question online, actually to me. From Federica Bertacchini, would be great to quantify the value that working with patients add to the health system. Remember the last slide that I showed? Are there any actual proposals, economic models and literature on it that decision makers and hospital leaders could look at? I think that's a very good question. I know that there are many studies that identified by subcategory. So it's clear that there is value in health literacy in patients. There's clear that patients who are followed up have better results than patients who are left to their own devices. But it's never done, to my knowledge, in a comprehensive way that actually measures the value of individual patient organizations. I would love to do that in truth. I mean, I've asked it many years ago also to DG Research to have a project on that, where we would compare with a control group, patients who are member of an organization and patients who are not member of an organization, to see whether there was any difference in outcome. And then, of course, that would be a great way of evaluating the value afterwards. I don't know, Jan, whether you are aware of anything in that respect.
No, I think there's a lot of economic data. I mean, I'm more, because I've been engaging in EU PADI and all the patient involvement in research. I mean, the community's been working for 10 years on all kinds of metrics to measure the financial value of patient engagement on, let's say, more effective clinical research, and the money that you save by not making a lot of amendments on clinical trials because the design wasn't thought through and from the beginning. So I think, as you say, Stefan, I think there are a lot of pockets where we have data about effectiveness of patient involvement. Whether that could all add up to one sum, I don't think that works so easily. But I think we have more data than we can actually make use of.
Right. Okay. Another question. Sorry.
If I could add to that, actually, there is a randomized clinical trial published in JAMA in 2017 by Ethan Bash, where they randomized sites, pan-cancer chemotherapy, patients walking into the clinic for chemotherapy, to receiving an iPad or not, based on site, to report their symptoms and become engaged in their healthcare, and there was a 15% improved overall survival.
Wow.
From this. This has been repeated. It was a plenary session at ASCO 2018. It's been repeated, and they just reported in JAMA again the progression-free survival, completely the same. They're still waiting for the overall survival data to mature. But this seems very clear that there is an untapped opportunity here that we simply need to figure out how to professionalize the medical community, not the patient community in this particular respect, in incorporating these outcomes.
Wonderful. Thanks for adding that. And I think that's the way we're trying to work, as I mentioned, is we're trying to persuade hospitals and industry that we work on the basis of their value. So we have to create added value for them. And I think the way that we work and the way the fact that they're actually engaged and spend time on that is probably because they see the value. Otherwise, they wouldn't do it, right? And I think we're starting to work with a coalition of the willing. And I think once they will see the results, the other ones will be left behind. And they will be jealous and say, well, our competitors are doing this, that, and the other. How come we're not having the same results? So I believe that there is a real model there that will work, and that we will work with the ones who are willing to cooperate. Thank you. Any other questions? Feel free to take the floor. I have another question. Some data demonstrate that patient satisfaction sometimes is not related to safer hospitals, as hospitals often have to take actions to be safe that patients do not like. How to find the balance between security and satisfaction? That's a good one. I know, Jan, it links to what you presented, so I'll give you the start.
Yeah, I think, I mean, it relates a bit to the data that I was presenting, and also the concerns about the difference between system data and individual clinical data or clinician data. I think it's hard to interpret. It's important to use a proper mechanism to measure that. And we need to take that kind of individual opinion out and get enough evidence to really evaluate comparative performance of different healthcare providers. I think that's important.
Right. Okay, thank you. Yeah, but I think that outcomes, of course, is the critical thing. And patient satisfaction and experience is an add-on thing. But it's relevant to keep it in check, because obviously it's linked to the outcomes. Patients who are satisfied where they're going, patients who have a good experience in the hospital probably will also be a little bit more compliant than patients who are not. Huh? Jonathan.
Yeah, I think my point was that that it's flexibility that is really key, because that allows systems to adapt to individuals, which is the whole point of putting the patient first, right? So it's not putting patients first, it's putting a patient first, and then the other patient, and then the other one, and then the other one. And it's the flexibility. So that's why I showed the immunoglobulin, because I'm sure there are many people who are very comforted by going to hospital, and that's fine for them, and they live close by, and it's all fine. It doesn't work for me, but the flexibility to have those three approaches, I think that's the message I wanted to get, is each of us has our needs and our lifestyle that we choose. How can turn it around? How can we as a medical support team and a hospital and the system best support that? Because I think instinctively it has to lead to better outcomes, right? I feel it does. And you see studies also of giving patients more control and more feel of control over their treatment also helps. So I think it's the fact, and flexibility is hard to design for, right? Because systems don't do that. They look at the average and they design for it, just like your slide said. But designing for flexibility to allow individual effort, I think that's something to aspire to.
Right. Okay. Other question might be data. I mean, the registry that you have set up in Armenia, is that run by you as an organization, or is that a state-run registry? Because I know some patient organizations in Europe manage to set up their own registry, which gives them, of course, access to the data, which gives them a lot of credibility in their advocacy work towards the authorities, because they own the data, it's their data.
No, our patient organization only mediated technical experts meeting across the border and built the cancer registry, but it is fully maintained and implemented by the public hospital, the National Center of Oncology, for its own part of data being entered. And the National e-Health platform is responsible for any other clinic that has cancer patients, and they are responsible for entering the cancer data into their own module. So in Armenia, we do have a law on protection of personal data, like the GDPR in Europe, and it restricts the access to personal data for different institutions and even for different people who perform various functions within that authorized institution or agency. It is only about maybe 10 or 12 people based on their positions and functions that they have access to the software, how to troubleshoot, how to fix the bugs, and also do the analysis of data entry. Analysis of the data that is entered, because data entry is done at the level of different operators at the clinics and hospitals. Right. But our organization doesn't have any control, any authority. We just helped them build this national thing.
Okay. Another question, what can patients do to have more access to this data? Because I know from my own experience, if you have data on the condition that you represent, that you advocate for, it gives so much more weight and persuasive power when you start talking to government officials that you have access to the data, that you can demonstrate if things improve, this is the benefit in terms of life saved or in terms of money gained. I think very often it's up to us patient organizations to come with the statistics to make it work. Jan or...
Well, Stefan, don't get me started on that one. That's really one of the topics I've been fighting for the last 2 years. You know, we're in one of Europe's biggest big data projects, IMI Harmony, which is a huge IMI-funded project to collect retrospective data from clinical studies that have long run, where we can, let's say, build a big data lake. And we have more than 110,000 patient cases on 9 hematological malignancies on the database. But I can tell that data sharing agreements for this is a pain in the ass. It takes us 1 to 2 years to get the legal departments of a clinic or the legal department of a pharmaceutical company to agree to share data of trials that have long been run. This drives me nuts. This is our data. I mean, it's our patient. The patients actually have given their data in clinical trials to do proper research. And lawyers in the clinics tell us that it can't be done, even though our data sharing platform is GDPR compliant. It is approved by an ethics committee, so there is no good reason actually not to share clinical trial data in a pseudonymous form in that. And I mean, this is just one example where I've been directly attached to that. And I think we need a total rethink on that. And if I now move into the political level, I mean, usually it's always, if you want to move cats, move the food. So I would say when we spend taxpayers' money on research, the data should be open access afterwards, or provided to researchers that have not been part of that research projects, because what we patients want is accelerated learning, and we don't want to sit on our data and not share it because they don't want other people to publish about it.
Right. I think there's one good example that I'll be with you for the question, don't worry. In Tuscany, all the public hospitals were part of an analysis made by the University of Pisa, and so they had to share their data in breast cancer, diabetes and hip replacement on 20 to 30 indicators by hospital. And initially there was a kind of reluctance from the hospitals to share their data because they said, yeah, the bigger hospitals are going to steal our patients. But now they noticed that actually not one hospital was the best in all the 20 or 30 indicators. So what happened now is that they shared their data, and so many years later, so 5 years after they started, all hospitals have improved on all indicators, which shows that transparency and understanding what are the practices behind the statistics, learning from each other, actually makes medical practice better for everyone. And it doesn't have to be heavy research. It's something that can be done in real time because the data are available. So I think this is something important to take into account.
Could I just add a point on this? You're aware of the EOSC4 development of the European Cancer Data Space, which is a very large European-funded project to address particularly these issues of providing a data space which, with agreements across Europe, that clinical trials data can be uploaded into a cloud with the principle of having access for researchers. Researchers, appropriately accredited, will be able to access and perform in that space their other ways of cutting the data or looking retrospectively or whatever you want to do without having to download the data. So the data remains in a secure environment, complying to all European privacy and GDPR regulations, and yet provides access for research, which is, it's in the early stages, and we had the stakeholders meeting on Tuesday last week.
Okay.
So it's in the early stages of design.
Okay, thank you for adding that. Come to the question now. Thank you.
Yeah, so Ananda Plate, Myeloma Patients Europe. I just wanted to, I think I'll start with saying that I really have a problem with the title of the session on patient satisfaction and the term of it. And as if, patient satisfaction, as if you were, those buttons when you go out of the toilet at the airport and you just click green or red, whether it was clean enough, or whether you felt comfortable having a pee. But it's not about that. And I mean, especially thinking about the fact that we have a representative of Armenia sitting on the panel, where I think the essence of it is patients wanting to live longer and wanting to live better. And so, I don't know, just maybe finding a term that better captures that. And it reminds me a bit of one of the quotes that Kate Morgan had on her slides a couple of days ago here at ESMO, where it says, it was a quote from some patient on CAR T, and it was like, CAR T for me feels like science fiction, or people in my country. And yeah, I just wanted to think about that. And the other one is around really the fact that, when patients undergo treatment, I think very often there is no expectation management. You do not know what you're entitled to. You do not know what to expect. And the same happened with follow-up. And I'm not sure how we're going to, because I've had several conversations at ESMO this year about exactly that topic, of people that are even experts and patients, but patient advocates as well, that do not know what to expect in terms of follow-up. And how can we, and this is a question to the panel coming to my point, what role do you think patient organizations have, but also other stakeholders in maybe setting those expectations from the beginning, and the patient community having a say on whether that is appropriate or not, or whether those expectations are higher, but from the very beginning, because once you're in that jungle, there's no way of finding your way if you don't know what the route is.
Right. Thank you, Ananda, for that question and comment. I think this is actually the crux of the issue. I think it's and that's, I speak 2-3 times a week. I speak at universities, at hospitals, at nurses associations, medical associations, to help them understand that it's important to have a formal and systematic integration of patient expectations and patient needs and patient insights into the way the medical system works and health policy works. I know it's an uphill battle. It's often frustrating to hear that even after all these years, some universities, of hospitals have still not understood anything of it. So it requires a lot of effort, goodwill also. But I think gradually, I think as Jan said, we're moving forward. We're not there yet. I mean, he uses a 10%. I'm a little bit more pessimistic. I say we have 5% of the road done, is the figure I usually have. But I think there's a long way to go. But I think it's only by demonstrating results, and I'm a very positive by nature, constructive. It's by demonstrating results that it actually shows that we are doing the right thing. And I think I'd rather work with a few hospitals and demonstrate fantastic outcome for their patient population with the right processes, listening to the patient, individual guidance of the patient throughout the treatment, that you can say, well, this is how it should work, and use that as a model that everybody then can use as an inspiration and learn from. So I'd rather look at what is actually positive, what are the best practices, and try to use that as a kind of a wonderful example that everybody can start copying.
Can I just add one more thing? I mean, I had to smile because of your example with the button. I was standing at a coffee machine here at the exhibition. There was this, are you a prescriber, which I had to answer right at the coffee machine. I clicked for 10 times that I'm a prescriber. I mean, that's not how generate evidence. I think what we really need, and I think we need to have that conversation at congresses like that. I mean, all the tools are there to generate proper evidence. I mean, Ananda, you were saying we don't know what patients expect. I think the tools are all there to actually assess what are the patient preferences, what are patients' unmet needs, what are patient satisfaction, what are the key drivers of patient satisfaction in a local healthcare setting. We have patient-reported outcome data or instruments to measure that. We have PREMs, PROMs, whatever. Are we using them? I mean, go around here at the conference and see whether these tools are being used. And when we talk about patient experience data, we very often then immediately go into an HTA discussion, say, can we generate this for HTA and for reimbursement? That's not the case. It is already, like you were saying, informing the patient community what our community wants. That's why we as advocacy organizations need to generate data. It is to inform the clinicians to say, this is what patients want, and maybe overall survival might be amongst that, but not the only factor. So we need to use these instruments more, generate robust evidence and present it here that everybody actually understands what patients want. And then we can talk about, does the clinical data relate to this? Okay. Or does healthcare system deliver to that on the policy sense? Evidence is everything, and you were saying the same. I think that's so important.
Right. Thank you, Jan. I think we've come to the end of our session. Maybe one word for each of you. So I'll give you the opportunity, Jonathan. I don't want to don't give it away. Say what you have to say, because I think it's important to have your...
triggered on the CAR T, and there is one thing I really worry about. I was at a CAR T conference, and the buzz around the research was incredible, and there's so much happening, and there's biospecifics and allogenic, and it's just incredible. But the gap between that cutting edge of science and the reality of hospitals everywhere. I mean, my treatment, 5.5 years ago, I had a trial. It's still not, in the Netherlands, still not approved by the government for general protocol. These things, so I think there's a system problem here where the research is fantastic and it's cutting edge and saving lives, but there's this massive widening gap between the reality, not just in countries, but even within the developed world. And I do think that's a concern.
Thank you, Jonathan. Ripa?
I have to mention that once again, in this instance, we do have a different practice, because maybe about 35–40% of cancer patients, when they are diagnosed with cancer, they are not told about that by their family members, relatives, and caregivers up till the very end, either the end of treatment or end of life. So what the patient could be expecting of the treatment, what the patient can expect if he or she doesn't know that she has cancer, but the cancer is being treated. That is a dilemma, and that is a very typical cultural thing that we do have in our cancer care system, that we are trying to address through patient education and also physicians' education. there is a separate branch of work that is focused on physicians, on oncologists, that you have to disclose that information to the patients. And we're still fighting and we're still working in that avenue, but when we come to that stage, then we will proceed to work on the expectations of the patients, because the clinicians have to be on the proper side of disclosing the information and not playing the trick with the relatives, don't say, don't disclose.
Okay, thank you. Jan, your, I won't say last words, but
You wanted the last
words.
word, patient-reported evidence.
Okay, wonderful. Great. I think that's a great word to end these sessions. I want to thank you all for your active participation and listening, and I want to thank the panelists for their great presentations and Q&A session. Thank you. Bye.